Good morning, everybody. You thought we'd be having a complete break right now, but we've got a little bit of sort of intermission entertainment. I am Neil Versel, staff writer for MedCity News. I'm joined up here by David Harlow, healthcare lawyer, blogger, and patient engagement guru.
Good morning, Neil.
Good morning, David. We're going to talk about freeing health records. We're going to be talking about patient engagement, which is one of the major themes of this conference, of course. It is kind of the central theme of this conference, actually. But we'll start out by talking a little bit about the Meaningful Use program and how patient engagement fits into that. We spent collectively about almost $30 billion to date on meaningful use. We've got EHRs just about everywhere, but we don't really have patient engagement. We don't have a lot of patient access to these records. We don't have a lot of interoperability, and I know that's something that's been sort of bothering you for quite a while, and gotten you more fired up about patient engagement.
Sure, absolutely, Neil. I mean, the issue with electronic health records as we have them today is that they're really built for a different time, a different age, a different set of uses. And today, as we're talking about patient engagement, we're talking about provider collaboration, we really need a different set of tools. But we're still working off of the Meaningful Use playbook. We're in Meaningful Use Stage 2. We're looking ahead to Meaningful Use Stage 3. And these sets of rules have a limited set of measures included there that address patient engagement.
Right.
So there are some metrics there, some metrics that have been scaled back considerably for Meaningful Use Stage 2, and hopefully they'll be scaled up again for Stage 3.
Well, I know. Well, first of all, I want to point out that you're wearing a blue button.
That's right.
Right on your lapel. So you're certainly in support of patient access to data. You're also a member of the walking gallery. You've got your jacket on that others will be able to see when you get up. But the patient engagement movement and the access to health data movement got a kind of an unintentional shot in the arm a few months ago from Meaningful Use when the CMS proposed rolling back the patient engagement requirement in Stage 2 of Meaningful Use. Really, it happened the Friday before HIMSS started in April when they put that proposed rule out and proposed rolling it back from 5% in Stage 2 to one single patient. That got a lot of people fired up, most notably Farzad Masashari, but you were kind of central in that as well, and you're playing a pretty big role in the Get My Health Data movement that's sprung up out of that.
Sure.
Out of that reaction.
Yeah, the rolling back from 5% of patients receiving records through the view, download, or transmit rule to a single patient per practice or per provider is really a dramatic change and a dramatic scaling back of the initiatives that the federal government has taken. And I think it's very important to move forward rather than back. There's been a lot of movement, a lot of certification activity in Stage 1 of Meaningful Use, and fewer providers to date have attested certification for Meaningful Use Stage 2. A big objection raised by some in the provider community is how can we be held responsible for something that is outside of our control, that being patient engagement, patient viewing, downloading, or transmitting their own records. Now, from my perspective, it seems that it is incumbent upon the provider community to explain to the patient community why is that important, why should we be viewing, downloading, or transmitting records. Certainly patients with severe illnesses or chronic illnesses are going to be more interested in accessing their own records. But as we're moving to a value-based system, we're moving to a system where patients are more responsible for the finances of their health care as well as for managing their own health care beyond the finances. It's going to be more and more important for patients to have access to their own data and the ability to see not just a snapshot of a personal health record, but the full electronic health record data, the full set of information that's going to be accessible to payers and providers as well.
Right. Now, do you want to talk a little bit about the open notes movement? That's
sure.
That's the notion. I think it started at Mass General and Intermountain and I believe is it
Beth Israel Deaconess,
yeah,
Care Group,
and Harbor View in Seattle.
Right.
And it's kind of spread around the country. It's the notion that patients should be allowed to see the entire physician note, all the clinician notes, unfiltered. Now, there's certainly some reservations that a lot of doctors had about that, but the initial results of the study that they did was almost unanimously positive.
That's right.
Yeah.
I mean, there's a historical predilection on the part of the medical community to hold those notes close to the vest, if you will, and share only certain bits of information with patients. Part of that has been couched in terms that have been seen over time as being relatively paternalistic, and in this day and age, not only for financial reasons, but also for broader patient self-determination reasons, patients are more and more interested in having full access to their health records. And what the Open Notes project has shown is that sharing the full patient record with the patient is in fact beneficial to the health outcome. Having a fuller understanding of what's going on, about what all the interconnections are between here and there, what the values of lab tests over time are looking like, what can be done to affect those lab values, and thereby the broader health of the individual, is empowering to patients. And that's something that these high octane academic medical centers have seen, something that you might not have expected to see in an academic setting.
Yeah.
But they've acknowledged that using the Open Notes approach, the patient satisfaction increases and outcomes improve.
Okay. Now, the Office of the National Coordinator for Health IT has acknowledged a lot of these problems, has even come out with a kind of a scathing report on what they called information blocking. Without naming names, we could kind of read between the lines and know
Right.
which very large health system vendors there are that they're kind of accusing of this. I'm going to go out on a limb and suggest that they might be in the Midwest somewhere. And ONC also earlier this year, late last year, and came out with a 10-year roadmap to achieve interoperability. Interoperability was supposed to be achieved in stage 2. They've kind of acknowledged that that's just not going to happen on this timetable, so here's a 10-year plan to do it. You believe that that's still too long?
Oh, it's far too long. I mean, I think that it is possible to have interoperability, true, meaningful interoperability, lowercase m. I'm not talking about meaningful use, but meaningful interoperability can be achieved in the near term. What is interoperability? It's defined in the regulations really as a combination of having a record locator service and having the ability for an individual, whether it's a patient or a provider, to see a record from one place and sort of have it pop up in another place. That's not really interoperability in my book, and I'm not prepared to wait 10 years to achieve that. What I'd like to see, and what I think we can see in the very near term, is creating really what I would refer to as an operating system for healthcare, an operating system that is able to pull records from multiple providers, create a longitudinal health record of complete EHR data that's accessible to patients, to providers, to caregivers, to payers, so that folks can see what that means all in one place, see how it works together, see lab values changing over time, see images, see reports about images all in one place over time, and to be able to have meaningful conversations around that information, where patients can post to that record, where clinicians can post to that record, and read messages from that longitudinal record in a way that promotes health of an individual patient over time and across care settings.
Okay. Now, what pieces need to be in place for this kind of thing to happen?
Well, the electronic health record and the whole meaningful use approach to electronic health records is really predicated on a system of health care that is maybe 5 or 10 years old. And that's just sort of, that's a natural outgrowth of the way we deal with regulation. We regulate, we address things that have happened historically rather than addressing things that we want to have happen in the future. So today's healthcare is more a healthcare system of collaboration. We're here talking about engagement. Engagement requires collaboration, and that is historically not something that has worked well in the healthcare industrial complex over time.
Egos get in the way.
Yeah, but sort of even more sort of at the structural level.
Okay.
We have organizations, we have multi-specialty medical groups, we have academic medical centers, we have tremendous silos of providers, which also create silos of information. And what the interoperability roadmap touches on, or where we are rather in the current stages of that, is sort of the ability to access information, but not truly the ability to communicate in real time across silos using that information to manage the care of a patient.
Okay. Now, if you were the one making the rules for meaningful use, for interoperability, or just for the industry to collaborate, how would you do things differently?
Sure. So I'd really look to collaboration as the key to the structure for what we need to have in place. And everything needs to serve that goal. So the open notes concept is central to that goal. It's open to the patient, it's also open to other providers, needs to be open to other providers across care settings, across care organizations. So if we build that sort of operating system for health information sharing, then we're going to be able to communicate more freely and more broadly across these silos. So it's not just about did 5% of patients access their information. It's more about what did those patients do with that information? Did they use that information to take the next step in an encounter with a provider, in engagement with their own care planning and care management, and in some isolated circumstances around the country, we're now seeing sort of next generation solutions looking at information that's been provided in a more traditional way and saying, how can we supercharge this? How can we use smartphone-based apps? How can we use the internet in the way that consumers experience the internet in order to drive engagement more broadly? And folks have been seeing that. And instead of looking at a 5% number as an impossible, unattainable goal, we're looking at much higher levels of engagement.
Okay. Now I remember the original proposal for stage 2 called for 10%, and a lot of people said, well, that's impossible. They lowered it to 5%, and a lot of us looked at that reg and said, oh, that's laughably low. And now here it is, you know, they're wanting to get it down to almost zero, to one single patient, just to prove that the technology works. How do you get I mean, we've been hearing also for years about patient-centered control of data, personal health records. All of these things are going to put the patient in charge, and it really hasn't happened on a wide scale. It's, you know, some very small, maybe some disease-specific communities, or for people who might be caring for somebody else, like an elderly parent or a sick child, but not for themselves. How do we change that? How do we get patients truly interested in being the ones in control of their health and their care?
I think you raise an interesting problem, and it's a conundrum, because essentially most of us, if we are relatively healthy, we really don't care about our health information. We only care about our health information when we're sick.
Yeah, and yet millions of people have gone out and bought wearable fitness tools like Fitbit, for example, and all it does is track your steps, and maybe you can sort of compete against your friends or say I've met this fitness goal, but it doesn't connect to anything. And that kind of thing could work in healthcare. It just needs to be connected. But
sure,
yeah, that's just one example. But
yeah, I mean, whether it's apps or devices like Fitbits, there's a tremendous fall off in engagement with users after several months or so. I mean, you've seen this over time. The challenge is to change the way in which we try to engage with people over time. So you can use the same platform for engagement, but you need to constantly be tweaking the approach to patients, because as humans we get bored. And we're going to get bored quickly if we have the same kind of prompt from an engagement platform. That's just going to get old over a while. We're not going to be interested.
And also, if you have to log into 3 or 4 different portals from all your different providers, you're going to get bored or frustrated and just say, hey, it's not worth it.
Sure. So really sort of reimagining this as an operating system for healthcare where there are a million different applications that can plug in to a universal data layer that has health data from across multiple systems, and having those applications reach out to patients in ways that engage them over time in a way that creates continuing engagement, not just engagement for 3 to 6 months. That's really going to be the key to maintaining and improving health and health status for millions of people.
Okay. Are there any existing technologies right now that show promise to be that operating system?
I mean, there are, I mean, it's a challenge to identify specific products and services. I am working with a company that has developed that sort of approach, and there are other bits and pieces of that kind of ecosystem. That are out
now
there.
Blue Button is just one component of a bigger picture. That's
right. So at this point, I would say Blue Button is an idea. There's there are a number of companies that have implemented different approaches to Blue Button and different approaches to taking that to the next level. And but the idea of Blue Button is basically the ability for an individual patient to very simply request and download a full health record from a particular system, particular provider, particular payer. And that's been implemented. It was implemented first in the VA system, and some of the large payers have done that as well.
But then you have to do something with the data. Yeah.
So I don't want a PDF of my health record. I want my health record available to me in a way that's connected to all of my other health records and to a lot of other kinds of information, and that's really the challenge.
Okay. Will we ever get to a point where the patient really controls the data?
Well, we can and we should. By law, a patient controls the data. It's been an uphill battle, it seems, sometimes for patients to obtain even a PDF of a record.
And it's been in the HIPAA privacy rule that's been in effect since 2002, and yet HIPAA keeps hospitals in particular keep throwing up HIPAA as an excuse not to give the data. Oh, we can't let this out because of HIPAA. Well, they're getting that all wrong. HIPAA says you must give the data to patients.
Right, absolutely. HIPAA absolutely requires that. And what's most important for the conversation we're having here is that HIPAA requires that a healthcare organization provide that data to a patient who requests it in the format that the patient requests it, if it is reasonably possible for the organization to comply with that request. So that means please don't send me a PDF. Please
now the if it's reasonably possible, they always say, well, it's not reasonably possible, so we're not going to do it. Or we're not even going to tell you that you have this right. You have to figure it out on your own.
Sure. So,
and I think Get My Health Data is trying to educate the public on that.
Right, exactly. So getmyhealthdata.org is an initiative that was kicked off as a result of that rule proposal in the HIMSS meeting. And I'm working with an organization, freeourhealthrecords.com, that allows for a request to be submitted through that platform to each and every healthcare provider that you've seen, and have that provider upload an electronic health record in a universal format. So it's going to be easy for the provider to do, and then it becomes easily viewable by a patient in sort of a social media type setting in a way that's familiar to all of us. You know, we all know what a Facebook feed looks like. So if you present a series of healthcare encounters and test results in that kind of format, and allow it to be shared, allow people to post to the feed and so forth, that's going to be very easily usable by the public.
But a big challenge is, unlike Facebook, this has to be secure.
Absolutely. We certainly see many stories all the time about challenges with security, but certainly this is something that has to be hosted and maintained in a secure environment.
All right. So we're just about out of time. I just want to ask you for any final thoughts on patient engagement and how to sort of break down all these barriers that have been in the way of patient engagement, and to get to this vision that so many people have talked about for so many years. Do you have any final thoughts on that, or any advice for the people here or the people who may be watching this back at home?
Sure. I think the number one issue that we need to address is consumer education. If there is greater attention paid to this issue and more people understand what's at stake, then this will become an issue that will capture the attention of the legislators, of the regulators in this country. Unless there's a crying demand for this sort of information, for this sort of response, then we won't get that sort of response from the regulators.
So you have to create the demand.
You have to create the demand.
And then demonstrate the demand.
Yeah, demonstrate the demand. Because we do only want this information when we have an untoward event, an unfortunate event. Or when, gee, I just got that test done and I want to see the result right away. If we build the infrastructure, and we have the infrastructure
Which
there,
is exactly what Dr. Beveridge from Humana said in the opening keynote, this episodic sick care, and it has to become health care.
Right. And by changing the incentives that we have and putting people more at greater financial risk for their own health care costs, we're incentivizing people. We need to take it to the next step and educate people about the importance of the data in this equation, and having a platform at their fingertips that can empower them to access data, to use data, to communicate about their health in a way that's going to maintain and improve their health over time.
All right. Well, thank you. I've been talking with David Harlow, a healthcare attorney, blogger, patient engagement advocate, and member of the Walking Gallery here at MedCity ENGAGE 2015 in Bethesda, Maryland. I'm Neil Versel of MedCity News. Thanks for tuning in.